Hi, my name is Atif Ghorbanzadeh. I'm a first-year internal medicine resident at Capitol Hill Regional Medical Center and a CardioNerds intern. I'm excited to invite you all to the AHA Scientific Session 2024 happening from November 16 to 18 in Chicago. Don't forget about Per-Session Symposia and Early Career Day on November 15, which will feature QCOR programming and international symposium. We will also have cardiogenic shock masterclass in the simulation zone. It's AHA's 100th birthday. Make it a special conference. CardioNerd Conference scholars will be there. So register today at scientificsessions.org.
And when registering, be sure to use the code NERDS, because if you're among the first 20 to sign up, you'll receive a free 1-year AHA professional membership. And with that, let's get to the show.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey CardioNerds family, this is Amit. On behalf of all of us at CardioNerds, we are thrilled to bring to you our Decipher the Guidelines series for the 2022 AHA ACC HFSA Guideline for the Management of Heart Failure. Get ready for short and bite-sized, high-impact, clinical vignette-based questions designed to highlight core concepts based on cutting-edge evidence that are relevant to your practice. The cases we use are hypothetical and created for educational purposes only. This series was developed by the CardioNerds and created in collaboration with the American Heart Association and the Heart Failure Society of America. It was created by 30 trainees spanning college student through advanced fellows, with mentorship from Dr. Anu Lala, Dr. Robert Mentz, and Dr. Nancy Sweitzer. We thank Dr. Judy Bezanson and Dr. Elliott Antman for their guidance along the way. So friends, join us as we get to learn about the heart failure guidelines and beyond from 16 leading faculty experts. And now, let's get nerdy.
The following question refers to 7.33 and 7.36 of the 2022 ACC AHA HFSA Guideline for the Management of Heart Failure. The question is asked by Palisades Medical Center medicine resident and CardioNerds intern Dr. Maryam Barkhordarian, answered first by CardioNerds Fit Ambassador Dr. Natalie Tapaskar, and then by expert faculty Dr. Robert Mentz. Dr. Mentz is Associate Professor of Medicine and Section Chief for Heart Failure at Duke University, a clinical researcher at Duke Clinical Research Institute, and Editor-in-Chief of the Journal of Cardiac Failure. Dr. Mentz is a mentor for the CardioNerds Clinical Trials Network as a lead principal investigator for PARAGLIDE-HF, and is a series mentor for this very Decipher the Guidelines series. For these reasons, and so many more, he was awarded the Master CardioNerds Award during ACC22. Welcome, Dr. Mentz. We are so happy to have you here today.
Dan, thank you so much. It's really a privilege to be here. I'm looking forward to the discussion and talking about how we translate guidelines into clinical practice.
The delight is ours. Maryam, take it away.
Thank you, Dan. Miss Kay Lutza is a 48-year-old woman with a history of CKD stage 2, baseline creatinine about 1.2 milligram per deciliter, and type 2 diabetes mellitus. She has recently noticed progressively reduced exercise tolerance, leg swelling, and trouble lying flat. This prompted hospital admission with a new diagnosis of decompensated heart failure. Transthoracic echocardiogram reveals LVEF of 35%. Ms. Lutza is diuresed to euvolemia, and she is started on carvedilol 25 mg twice daily, sacubitril valsartan 49-51 mg twice daily, and empagliflozin 10 mg daily, which she tolerates well. Her eGFR is at her baseline of 55 milliliter per minute per 1.73 square meters, and serum potassium concentration is 3.9 milliequivalent per liters. Your team is anticipating she will be discharged home in the next 1 to 2 days and want to start a spironolactone. Which of the following is the most important regarding her treatment with mineralocorticoid antagonist? A. The spironolactone is contraindicated based on her level of renal impairment and should not be started. B. Serum potassium levels and kidney function should be assessed within 1 to 2 weeks of starting spironolactone. C. Eprolon confers a higher risk of gynecomastia than does spironolactone. D. The patient will likely not benefit from initiation of spironolactone if her cardiomyopathy is ischemic in origin. Natalie, what do you think about this question?
Thank you so much for this question, Maryam. That's really important. So the correct answer here is B. Serum potassium levels and kidney function should be assessed within 1 to 2 weeks of starting spironolactone. It's very important to closely monitor renal function and serum potassium levels when starting this medication. MRAs, also known as aldosterone antagonists or anti-mineralocorticoids, show consistent improvements in all-cause mortality, heart failure hospitalizations, and sudden cardiac death risk across a wide range of patients with heart failure reduced ejection fraction. There are 3 main trials to know when we are discussing MRAs. The RAILS trial looked at spironolactone versus placebo in highly symptomatic HFrEF patients with ejection fraction less than 35% and NYHA class 3 to 4 symptoms. The EPHESIS trial looked at eplerenone versus placebo post-myocardial infarction in patients with LV ejection fraction less than or equal to 40%. And finally, the EMPHASIS-HF trial looked at eplerenone versus placebo in less symptomatic heart failure with reduced ejection fraction. These patients had an EF less than 35% and were NYHA class 2. Altogether, these trials have shown that MRAs confer improvements in all-cause mortality, heart failure hospitalizations, and sudden cardiac death in patients with heart failure reduced ejection fraction. Importantly, these benefits have been demonstrated across a wide range of heart failure reduced ejection fraction severity and etiologies, including ischemic cardiomyopathy. That makes option D incorrect. Therefore, in patients with heart failure with reduced ejection fraction and NYHA class 2 to 4 symptoms, an MRA, spironolactone or eplerenone, is recommended to reduce morbidity and mortality, provided that the eGFR is greater than 30 and serum potassium is less than 5. Careful monitoring of potassium, renal function, and diuretic dosing should be performed at initiation and closely monitored thereafter to minimize the risk of hyperkalemia and renal insufficiency. This is a Class 1 level of evidence A recommendation. MRA therapy in this context provides high economic value. Now, in terms of adverse effects of MRAs, one of the wrong answer choices was regarding gynecomastia and MRAs. So let's talk about some of the adverse effects of these medications. So both spironolactone and eplerenone are excreted by the kidney, and due to their inhibition of aldosterone signaling, they reduce potassium excretion in the urine. For these reasons, the initiation of MRAs is contraindicated in patients with an eGFR of less than or equal to 30 or a serum potassium greater than or equal to 5. After starting or intensifying MRA therapy, serum potassium levels and renal function should be rechecked at approximately 1 week, 4 weeks, and then every 6 months thereafter, provided there's clinical stability. As we all know, hyperkalemia can increase the risk of ventricular arrhythmias and death. Unfortunately, changes in potassium levels often results in de-escalation or discontinuation of RASI therapy and subsequent loss of the long-term cardiorenal benefits of maximally tolerated guideline-directed medical therapy. So this raises an interesting point about the utility of prescribing medications that are potassium binders. For example, patiromer or sodium zirconium cyclosilicate. The utility of prescribing potassium binders such as patiromer, sodium zirconium cyclosilicate to improve outcomes by facilitating continuation of MRA is still uncertain. These medications remove potassium by exchanging cations, leading to increased fecal excretion and thereby lowering serum potassium levels. They have been FDA approved for treatment of hyperkalemia for patients who are on RASI therapy. Therefore, the use of potassium binders, such as patiromer and sodium zirconium cyclosilicate, to improve outcomes by facilitating continuation of RASI therapy in patients with heart failure who experience hyperkalemia, that's a potassium greater than or equal to 5.5, has now received a Class 2B recommendation. This is a level of evidence BR. But the overall utility of these medications still remains uncertain. In the DIAMOND trial, patients with heart failure and reduced ejection fraction and hyperkalemia were randomized to receive either patiromer or placebo. In the run-in phase of the trial, all patients were started on patiromer, and then subsequently RASI therapy was initiated or optimized. After this, patients were randomized to either continue or stop the patiromer. The hard clinical primary endpoints of time to cardiovascular death or first cardiovascular hospitalization were unfortunately changed to mean change in serum potassium due to some challenges with recruitment during the COVID pandemic. That being said, there was a significant reduction in mean change of potassium in the patiromer group versus the control group. Additionally, 85% of the patiromer arm was able to be optimized on RASI therapy while taking the medication. So aside from hyperkalemia, other troublesome side effects of MRAs can include gynecomastia and vaginal bleeding. Eplerenone results in lower rates of these side effects compared to spironolactone, given the greater specificity for the aldosterone receptor. So overall, the main takeaway here is that mineralocorticoid receptor antagonists, spironolactone and eplerenone, reduce all-cause mortality, heart failure hospitalizations, and sudden cardiac death risk in a wide range of patients with heart failure with reduced ejection fraction. But it's very important to monitor renal function and potassium levels while on MRA therapy. Dr. Mentz, I'm wondering if you can comment a little bit about strategies for troubleshooting MRA dosing, especially in patients who might have fluctuating renal function levels or might be admitted with acute decompensated heart failure. And if you could comment a little bit more about potassium binder medications and what the future might be for these.
Yeah, thanks so much, Natalie. So I think you really summarized such an important case here. And I would just reemphasize the points around really working to get all of our patients with HFrEF on an MRA unless there's a contraindication. I think this is one of the largest gaps in the foundational four therapies. We know that about 2/3 of patients that have an indication for MRA for HFrEF are not receiving it in the US. So really empowering the CardioNerds team now to think as you're going out and taking care of patients, when you see HFrEF, think quad therapy and make sure you're getting on MRA as one of those key foundational therapies, because it's a huge gap, especially here in the US, but in some other areas of the world as well. So again, I think getting on MRA is an important point. As you're talking through some of the challenges of thinking about troubleshooting anything around this, I think one of the key messages I would convey is that we need to get over this fear of a potassium of 5.1. We're so programmed, we see in the electronic health record of 5.1, this lights up in red and sends off these alarm bells. But what we know is that we can very safely initiate MRAs in patients with HFrEF. We certainly need to do it in line with the guidelines, so they give perspectives, as you noted, around a potassium greater than or equal to 5 and a GFR less than or equal to 30, where we start to worry about it. But really, I would emphasize the need to monitor closely. So as long as you're noting, the renal function is stable, we can monitor their potassium, we can get patients on spironolactone or eplerenone, and then we just need to check that. So this example here is a perfect one where if we're seeing them in the hospital or in clinic, we can start the therapy. And then at that early post-discharge follow-up period, you can make sure to get repeat labs, make sure their potassium's okay and that their renal function is still stable. You nicely talked through some of the recent data with potassium binders, most recently the larger clinical trial Diamond coming out, showing us the utility of potassium binders such as patiromer. So these are therapies where if a patient is struggling more with potassium, and you've talked through some of the other things that we can explore in terms of dietary potassium intake, mitigating other challenges there, then if they're really still struggling with higher potassiums based on the criteria of Diamond, then you can think of starting patiromer in order to enable RASI therapies. So we do have that evidence base now from Diamond, as you noted. And then finally, I would say just some of the difficulty when a patient comes into the hospital, they're volume overloaded, their renal function is worse than normal. Really what we know is that those first couple of days we can decongest, get a good bit of diuretic during that time, with often their potassium level coming down, even if that was higher as they first came into the hospital. And then we're often still continuing IV diuretics, transitioning to oral diuretics. So that gives us the opportunity to safely start spironolactone, to monitor their labs. Very commonly, we're getting labs every day, so you can keep a close eye on this. We know that MRAs really do not impact blood pressure much. So that can be in contrast to some other medications you might also want to start. We could get spiral on pretty early in the hospital course after their renal function and potassium have stabilized. and then have that early post-discharge follow-up as well. So I think you've really summarized the nice points and given us some key updates from the guidelines, as well as more recent data from the Diamond program as well. So just in summary, I would say highlighting the importance of getting all of our patients on an MRA for HFrEF unless there's a contraindication around GFR or potassium, making sure we're starting these therapies in the hospital. That gives us a prime opportunity for close follow-up of labs in the post-discharge setting. And again, usually checking labs at 1 to 2 weeks. But if you are still struggling with elevated potassium despite dietary changes and optimizing volume status, as well as considering other medication changes, then it is reasonable to consider therapies like patisiran for RASI enablement. So thanks again for the opportunity to connect with you all. I've enjoyed this conversation, and hopefully some of these pearls will help in your clinical practice. Thanks again.
Thank you, Dr. Mentz, for your great comments.
Absolutely. Thank you all.